Thank you so much for the invitation, and Venki put me to reshape the whole session, and I'll follow on Professor White and Professor Mackenzie's talk about what's going on, but I'm going to show you a lot of stuff that some of you might not know and is becoming the basics of vascular surgery in this current generation Z or whatever generation we are in now. Can we have audio, please?
Perform all coding jobs in seconds, including blockchain development. While this AI is already outperforming accounting firms. Meanwhile, the new graphic design AI aims to automate graphic design and could minimize the need for...
Relax. Because in a future where AI does most of the work, there'll be one thing that humans will finally get to do all day long. Nothing.
I think this has summarized your AI talk totally, so that without Professor White complaining about what was going on. Innovator and early adapters. Clinical community is diverse. One end of spectrum are innovators and early adapters who are enthusiastic about adopting new ideas, or late majority and laggards, which we have a lot of them around us, who will never accept any solution, no matter how many others use it or how promising it will be. So we went on to the fifth cardiovascular revolution, and I've said that almost 2 years ago. Now I think we are just moved immediately to the sixth cardiovascular revolution. It's essential to understand that with time, AI will grow exceptionally in cardiovascular medicine. The significant economic burden associated with initial implementation will decrease, not only over time, but also the return on investment will be worth the initial capital buy-in. And you could see the analysis that we have performed for that talk. Current obsolete diagnostic algorithm. Currently, all professors in here happy to teach their student, do history, take clinical examination, do a proper imaging, maybe do a little bit of genetics. Then you have to go to Department of Diagnostic Medicine to get your diagnosis, plan, and prognosis and management and lifelong care. That's obsolete. If you're doing that now, is not the standard of care. The standard of care is digital twin, where you're going to have skin tattoo monitors on your hand to over all the time monitoring what's going on, and then you discover that you have a carotid plaque. You get this microorganism into your eyes, goes through natural orifice into your supraorbital, supratrochlear artery, goes down to your carotid artery, eat all the carotid plaque out, and then you go in through natural orifice again, pee it out, and we finish the story. That's the future that nobody's talking about. So our vision is collaborate with industry and academic partners to create a groundbreaking solution to challenging complex cardiovascular problem. A three-phase groundbreaking project of big data collection, creation of an intelligent kinetic digital twin of the aorta and the heart for target discovery, and testing of fault-tolerant self-repair, self-healing solution for cardiovascular neurocrystopathy. And I'm going to come to the neurocrystopathy, how we done reverse engineering to understand how we could fix the problem that we are facing. Vascomic integrated techniques mandate new ontological biological approach for cardiovascular disease. The old idea that I'm going to do a clinical trial using a human being as a guinea pig is gone. The lure of obtaining large data set will replace any clinical trial, and investigator must understand technical and biological strengths of Vascomic approaches. And this is the way that we're going to the future. We'll be doing virtual clinical trial simulation, no need for any sort of human injury, virtual photonic aided clinical trial. You'll be able to understand the solution, you'll be able to correct it yourself, and you'll be able to have the result available within a day for a full clinical trial. Now let's go back to Earth again. Radiation levels are currently dangerous. Modern imaging technology should be considered a top priority in every center providing endovascular management of aortic pathology in order to attract trainees and educated patients. And Venki wants me to talk about it because he's babysitting the EGG project in his practice. So we know that FIVAR and BIVAR carries the greatest exposure risk. In fact, if you're doing a tibials, you have more exposure than doing a FIVAR and BIVAR. So we start applying the artificial intelligence, but in here we're trying to put a little bit of supercomputer and quantum computing in what we're trying to find. So first of all, the first thing that we found that professional fee do not equate for lifelong risk of radiation exposure for physician, hospitals, and patients. So basically, you're doing all of this happy ending cases but you're going to have a meningioma in your brain, or you're going to get leukemia, and you will die. So what's happening? It's crazy. So we went on to try to do a little bit of digging down to see what's the transformative advancements in vascular practice. Vascomics identify resilient vascular trainee, accelerate discovery of trainee vascular phenotype that withstand high radiation exposure. So when he comes for the interview, you will not take the wimpy guys who are going to develop cancer. You're going to get the guys who could tolerate radiation up to the extent that they will never die. Then we go to the AAA SAC volume mapping, enhanced predictive modeling, and personalized treatment strategy at guides intervention based on SAC expansion as a surrogate endpoint. And lastly is the dynamic fusion imaging as it reduces interoperative radiation, intervention duration, and the contrast used, and I'll show you some examples about it. Leveraging advanced genetic screening to identify RNA-resilient candidate against radiation, ensuring safer selection of vascular trainees so that they don't sue you, that you know that I could get cancer from radiation, and you appointed me as an intervention vascular specialist. This approach prioritizes radiation resistance, future vascular surgery, minimizing long-term health risk, and mitigating medical legal liabilities while redefining safety standard in vascular medicine. Now, all of you know what happened with DeepSeek. You know what I mean? 5 million versus 10 billion. And this is a few guys sitting in a garage was able to overturn what Mr. Elon Musk's trying to buy. So predict disease risk using tools like XGBoost, and try it. And the SHEP is free online. Try it. It's amazing. Guide patient care on precision risk profile. They come to your office with the decision of their case. And if you don't know the tricks, you'll be like a letter. You can't read and write. You don't understand what they're talking about. You need to start talking like the patient. They are much more advanced than yourself in your career. AI-driven MRI, cardiac MRI analysis predicts cardiovascular risk. Professor Zaran was talking about that yesterday. I think we moved away from that FFR now. Machine learning identified novel marker for prognosis. AI outperformed traditional assessment in predicting outcomes, and it was done within 30 seconds. And I'll show you examples about how to do that. And the crucial role of radiomics in cardiovascular, it enhances, identifies, predicts, and transforms cardiovascular care through advanced imaging analysis, stuff that you don't see with your eyes. So Vascomics identify atherogenic pathway and creates therapeutic target to address AAA and PAD with CRISPR and gene editing. Moreover, which is very important, it have shown that global myocardial texture alteration detecting diabetics and predicting sudden cardiac death with MRI radiomics. With normal MRI, you know whether this guy going to get sudden death or not. Nobody had this ability before applying our algorithms. Now, this is a new one, and I think that a lot of you didn't know anything about it. We know that cardiovascular comes from inflammation, and the perivascular fat index is the way going forward. It quantifies cardiovascular inflammation and non-invasive biomarker for inflammatory atherosclerotic burden. It detects high-risk plaque missed by conventional assessment. It targets prevention and personalized intervention by combining anatomical function, biological metrics, and optimized cardiovascular management. As you can see that, we have done the anatomy assessment, we have done the plaque characterization, we have done the CT perfusion, but we need to know what's going on. So it's the perivascular fat index. Now, advanced imaging, you know about CIDR, and a lot of people are using it. Currently, it's 50% reduction in radiation exposure, 20% reduction in procedure time, and 20% reduction in use of contrast agent. And it is dumb-proof to be used in any case. And the dynamic volume-based insight as it tracks SAC volume changes, because Venki asked me, we need to see the advances in AI in management tools and diagnostics. And this is what you have over there. So you don't intervene except when you know that this sac will expand, or this sac will be stable, or this sac will shrink. You cannot predict. The AI have algorithms to tell you exactly what's going on. Data-driven decision-making reduces reliance on subjective MDT, to which some of them have no idea, and they have a little bit vendetta against you, give you a wrong decision, and you find yourself exposed. So MDT is for the birds. You need to get an AI MDT system in your hospital to protect you from nonsense, inexperienced people sitting on the panel. Now, intelligent smart fusion imaging, they request AI. There's no other way to avoid stroke in complex arch procedure. This is the first arch procedure done in Europe, done by myself 2 years ago. It's 2 inner branches. We never use the carotid for any endovascular stenting for the arches. We do the carotid bypass. We do it as a necklace. We do not put it directly pharyngeal because you cannot put it close to the esophagus. It will get infected. And then after that, we do the case routinely as everybody have done it. And I'll show you how simple it is. Both of them are inner branch, left subclavian and nominant, and it takes almost about 2 hours to 2.5 hours, depending upon how slick you are. Very nice, very competent to do, and we have done 4 of them, and I'm telling you, that's the way forward. But without the fusion imaging and the AI and machine learning, we were impossible to do such cases. Now, fusion for Bivar Assist, again, all our cases have been assessed, 12-fold lower DAP, 28% procedure time reduction, and 70% contrast media. Now, that's the future. My IQ image guided system, the AutoWrite 6P control device, Omni XR augmented reality, and the OPS AI navigation system. All of them are available. All of them are commercially available. I think Venk is using the Force, which is part of that. And I think that you need to start knowing that if you do not come to the 6th cardiovascular revolution, you will be seen as if you are like the guys who cannot deal with computers. It's impossible. You need to start educating yourself. And trust me, you are old but not obsolete, so you need to start learning from start. Mr. Chairman, ladies and gentlemen, transforming antiquated medical education through AI and big data analytics both will set to pioneer a new era in precision medicine, redefining vascular disease management. Future-proofing vascular surgery by building a resilient workforce equipped with advanced scientific insights and predictive tools to address modern challenges with confidence. Vascomics identifies specific marker driving sac growth or stability over time, offering tools for precision monitoring and patient-specific intervention. Future direction integration of Vascomics and gene delivery technology and microbiome manipulation will transform PAD and AAA management by enabling safe, efficient, and targeted intervention, improving patient outcome and life expectancy. Thank you so much for the opportunity to present today.